So my name is Hala Danoon. I'm a senior clinical pharmacist. I am a GP-based pharmacist. So I work within one practice, and that's Modern Hall Medical Center. I'm a non-medical prescriber. I have special interest in women's health, but I also do prescribing for diabetes, asthma, COPD, DOACs, and anything in between. Today's presentation is about constipation, causes, management, and treatments of constipation. Next slide, please, Nisha. So NHS 2017 explained constipation as not opening the bowels 3 times in 1 week. The stool is difficult and large to pass, and it is hard and lumpy. Next one, please. So it's important to look at the prevalence of constipation in the different populations, and that sometimes can help you make a clinical judgment. So the evidence shows that the women are more likely to have constipation than men, and that starts from the young age, even of children. A lot of patients who visit A&E are young girls with constipation, so you will see it even at a younger age. So women are normally about 2 to 3 times higher prevalence in getting constipation than the male population. It is also more prevalent in the elderly, and that affects about 33.5% of people aged between 60 and 101. This setting as well have an impact on the likelihood of having constipation. So patients who live in their own homes have, we're talking about their own kind of like environment, are about 30 to 40%. That percentage goes higher when they go into a care home, but goes significantly higher when they go on a long stay on wards in hospitals. So that's about 70%. And that could be very directly related to fluid intake and mobility. It is very common also in pregnancy. So about 40% of women might experience constipation, and that's due to physiological, biochemical, and dietary changes because of the pregnancy. And also evidence has shown that Black patients have also higher incidence of constipation than, especially in the deprived socioeconomic groups. Next one, please, Nisha. So how do we diagnose and assess constipation? So it's very much about the patient's experience. They have their normal bowel habits, and if that changes, even though if you're comparing that one patient to another person, you will think, okay, they're not constipated. But we need to take their experience as the most important part of the assessment of constipation. Also, the duration of the constipation, the frequency, consistency. Is it hard? Do you take a long time passing stools? Is it lumpy? All of these symptoms. How long has it been going on for? Has there been any changes to your diet? Have you tried anything? All of these information will help you assess and diagnose constipation. Bristol stool chart is widely used in hospitals and clinical settings. Next slide, please, Nisha. And this helps the patient to identify and help us understand if they have what kind of a stool are they passing. So their understanding of constipation might be different than yours. A lot of the clinical understanding of different conditions is different between a clinician and a patient. Next slide, please. So what are the risk factors of developing constipation? So first one is the social aspects, and that includes the diet, where you have a low fiber intake, which includes your fruits and vegetables. Also, difficulty accessing a toilet or changes to your normal lifestyle routine. Lack of exercise or reduced mobility, like after an operation or a serious illness. Limited privacy to using a toilet could be also one of the factors. Low education levels or socioeconomic deprivation or family history of constipation. So all of these aspects we need to take into account when we're assessing a patient to see what is causing, because that would help us understand the problem and how we can provide the appropriate advice. Psychological aspects as well. Anxiety and depression can have an effect on food intake, appetite, and therefore affect constipation. Somatization disorders, eating disorders, or history of sexual abuse. Physical, we said female as a gender, they are at higher prevalence of having constipation, older age as well. If there's pyrexia, poor fluid intake and dehydration, immobility, these are other options that can affect constipation, and probably we can focus on this during the summertime. Sitting position on a toilet seat in comparison with squatting. There will be a slide which shows you a toilet positioning that can help open the bowels more easily. Next slide, please, Nisha. So if we try to categorize constipation into 3 different categories, a primary cause is there's no underlying cause, and it's largely associated with lifestyles. As we said, the mobility, the diet, the socioeconomic. So these are primary causes. The next one will be the secondary causes, which is due to a factor that has affected their intestinal mobility. So like physiological or medical conditions, these things can affect, like Parkinson's or diabetes. These conditions can affect the GI within a patient, and that will cause constipation. The other one is the iatrogenic causes, which is a side effect due to medication, and which includes, I think the most well-known one is opiates, but there's quite a lot of different medication that will come through that can cause constipation. Next slide, please. So some of the possible secondary causes for constipation, we said, is medication. And as I said, there's quite a long list of different medication that can cause constipation. That's because of the mechanism of action. So aluminium-containing antacids, iron, or calcium supplements can affect the constipation rates. Sometimes it depends on the salt. So aluminium definitely can affect the constipation. But calcium, it depends very much on the salt of the calcium. Iron has either diarrhea or constipation. So you have patients who will suffer from diarrhea because of the iron, and others will be having constipation. We said analgesia, specifically opiates, so up to 80% of patients who take opiates will experience constipation. Some non-steroidal can also cause, I think if you open the BNF, and this is being completely honest, I think if you look at under any drug on the BNF, you will see causes either GI disturbance, constipation, or diarrhea. So everybody reacts differently to the drugs. Sometimes it's not the drug, but the excipients. Antimuscarinics such as procyclidine and oxybutynin, because the way they reduce the prokinetic movement of the GI can cause constipation. We said antidepressants such as tricyclic antidepressants, because again, they have anti-muscarinic effect, so they will slow down the GI. Antipsychotics such as amisulpride, clozapine, and quetiapine. So the MHRA has an alert for clozapine. Every time we do a medication review for clozapine, we have to ask for symptoms of constipation. It can cause a lethal obstruction of the GI. So it's a really important thing that we ask about clozapine every time we do or issue a prescription for the clozapine. Antiepileptic drugs as carbamazepine, gabapentin, and pregabalin, phenytoin, all of those, again, because of the way they work and they affect the channels and relax the muscles. So these can increase the prevalence of constipation. Antihistamine as hydroxyzine, antispasmodics, again, like hyoscine, because they dry and reduce movement. Calcium channel blocker like verapamil, and diuretics. I think somebody's not muted. Diuretics as furosemide, and the reason being is because they're passing more urine, so it causes some form of dehydration, and therefore it can cause constipation. Next slide, please. Organic causes like endocrine and metabolic diseases. So we said diabetes. The whole condition of diabetes can have an effect on the neurosensitivity within the body, including the GI, and that can reduce the sensation of the movement of the GI. Also slows it down, and that can cause constipation. Hypercalcemia and hyperparathyroidism, hypermagnesemia, hypokalemia and hypothyroidism. All of these conditions can lead to increased prevalence of constipation. Myopathic condition where there's a slowdown in the muscles themselves and they don't respond can have an effect on constipation as well. Next slide, please, Nisha. Neurological conditions like multiple sclerosis and Parkinson's, any spinal cord injury, cerebrovascular diseases, or autonomic neuropathy, again, due to diabetes, can have an effect on the bowel movement. Structural abnormalities within the GI, like anal fissures, strictures, and hemorrhoids, because the patient will be worried about pain, so they will hold on and they don't go to the toilet, and that will make the problem even worse. Colonic strictures, like following a diverticulitis, ischemia, or surgery. Inflammatory bowel disease, they can have bouts of constipations and diarrhea. Obstructive clinical mass lesions like colorectal cancer, so we need to be aware of family history, how long has it been going on for, are they having overflowing diarrhea, etc. Rectal prolapse or rectal ascites, or postnatal damage to pelvic floor or third-degree tear. So again, we need to make sure if a woman just gave birth, having problems, we need to make sure that she's taking laxative to help pass stool rather than getting worse and more complicated. Irritable bowel syndrome can also, depending on the flare-ups, have bouts of constipation or diarrhea. Next slide, please. So how to avoid constipation and what is the general advice for that? So the first one will be through diet, and that by promoting a healthy, balanced diet, rich with fiber. And the main thing I think the advice we give is to have more vegetables than fruits, because fruits has also sugar content. So the really healthy option is your leafy vegetables, because they have higher fiber content. But with that as well, you need to drink the water for it to work. So that's why it's important for us to give the advice about increasing the fluid intake between 2 to 2.5 liters per day, alongside the vegetables and the healthy diet. Mobility and exercise, because most of our jobs are sedentary and sitting in chairs, the bowels don't have as much movement, and the movement is only not just the bowels, but even the abdominal muscles, where they can't like push against your intestine. That by itself helps the movement of your digestive system, and that helps to maintain a regular mobility of your intestine. Toileting, so a good routine and toilet habits can also help prevent constipation, and that is mainly, let's say, for the children who sometimes are so busy with gaming or sitting in front of a screen and they don't want to go to the toilet. So building healthy toileting habits and routine is very important to avoid the problem to progress. Next slide, please. So effective positioning. When the knees are higher than the hips, that helps open up the bowels in a natural way and makes it much easier to pass the stool. So sometimes it's a good idea to give that advice if they have like a footrest that they can put in the toilet, where they can lift their foot and rest it on this stool, and that would help open up the bowels more easily than when the knees are at level with the hips. Next one, please. So there is quite a wide range of laxatives available to be prescribed, but they work in different ways and we prescribe them differently. The main reason why we prescribe laxative is number one, to make it easier to pass, smoother, more softer, less straining, and hopefully more frequent, where they can establish a healthy bowel movement. Out of these laxatives, we have what we call a bulk forming laxative. So they work similar to a rich fiber diet. So the main one that we use out of this list is the SWL husk, and comes as sachets. The effect of the this kind of like bulk forming laxative takes between 2 to 3 days. So it's important that we tell the patient, okay, don't expect to open your bowels immediately. It takes time. Some of the information that we need to tell them is they need to drink plenty of water, just as we said, because we have high fiber in there. So we need to really make sure that they drink water with it. They don't take it and go to bed, because then that means they're not going to drink water, and that can lead to a build-up in their intestine. We should not prescribe it when we are suspecting any kind of obstruction in the intestine. Okay, so that is your SWL husk. The next one is osmotic laxatives, and again, they take about 2 to 3 days. It's important to tell the patients about the number of days or hours that they should expect for this medication to work, so they don't contact you again, or they don't call the GP again requesting another prescription that they took the laxative 24 hours ago and it's not working. Osmotic laxative, just like the name says, it works by absorbing more of the fluid into the intestine. So that will produce distension, that will also stimulate peristalsis, so there's movement, and that's, I think, why these normally come with colic, especially lactulose. So the patient might say, oh, but I feel bloated, I have colic. It is the way that they work. They will take 2 to 3 days. The beginning might be a little bit hard off the stool, but it starts to go smoother and softer. Stimulant laxatives, they normally take between 8 to 12 hours to work. And the way they work is by stimulating the colonic nerves that give that cramps feeling when they take these medication. Especially with senna, they will find it that after about 8 hours, they start to get cramps and contractions in their abdomen, and that makes them want to go to the toilet. Senna is a natural laxative. I will mention it in one of my case studies a little bit later if we have time for that. There's also Pisactyl and sodium bicossulfate. Now, the sodium bicossulfate is mainly used for bowel emptying before procedures like endoscopy, because it comes into a liquid form as well, so it's quite useful to use before a procedure. Donkey has 2 actions. It works as a surface wetting laxative and also as a stimulant. So it's quite a nice one to use for elderly, frail patients where you don't want them to wait too long. You want it to have a quick and yet smooth stool at the same time. It is considered a weak stimulant, but still we can use it in association with other laxatives as well, as long as they don't work in the same way. Prokinetic laxatives, they are a high serotonin 5-HT4 receptor agonist. They stimulate intestinal motility. I have not seen it in use, to be honest. They are used by specialists for chronic constipation. Next slide, please. So now that we know that there are different types of laxatives, I thought it might be useful to understand when to use which one as a preference. So for acute constipation, so somebody having a short, sudden onset of constipation, what would we go for? The first one would be a stimulant laxative, like senna, for example. We can add a softener to it if they are really, like, especially for children, if they are suffering for an acute constipation, it's very hard. We can give them stimulant, but that will take about 12 hours, 8 to 12 hours. So we can add a suppository to it that will help things to go a little bit faster. Laxative can be stopped once stool becomes soft and easily passed again. Okay, so that is what our different ages. If there is a possible of fecal impaction, microgold is our first one to go to, and we can prescribe it in high doses. They can take up to 8 sachets per day. So what they need to do is each sachet can be dissolved in half a glass of water. But you can ask them to dissolve a first sachet in a jug of water, leave it to the side and drink it throughout the day, and then another one in the afternoon where they drink it throughout the day. Now, we can also build up in the increase of the movicol, or once they open up their bowels, we start to reduce. If resveratrol is insufficient or not fast enough, we can consider suppositories as well, either glycerol or bisactol, to help with the constipation. We can use mini enema or docusate as a softener and a weak stimulant. Sodium citrate is another osmotic that can be used if the response to the macroboles and the suppositories is not enough, and then we add on the sodium citrate. Now, sodium phosphate enema is a large one, so we can also use it when there is a cardiac or electrolyte disturbances, like in renal patients. It's important that we use it in the correct positioning as well to avoid any perforation of the rectum. Moving on to the chronic constipation. So let's say chronic constipation due to a disease, for example, let's say for Parkinson's or due to diabetes. We need to look at a long-term management for these patients. So the first one will be bulk forming laxatives, because this is going to work as increased diet that is full of fiber kind of thing. But also, when we prescribe the bulk forming laxatives, as I said, we need to give them the instructions when to use it, how to use it, and when not to use it. We can add or switch to osmotic laxatives. If the stools are soft but remain difficult to pass, we can add a stimulant laxative. So sometimes for, let's say, elderly, where let's say for a patient who has Parkinson's, the stool is soft but they're unable to pass it out easily, then we can add a stimulant like a senna that helps to have a soft stool and at the same time to be able to pass it out. If we have an elderly or immobilities, then again, it's a stimulant laxative just to help them with the contraction of the intestine. Laxative can be withdrawn or gradually once bowel movements occur easily. The problem with the stimulant laxatives is after prolonged use of these stimulant laxatives, they lose the intestine itself will lose its ability to produce or to have that stimulation naturally. They become so reliant on the stimulation from the laxative that they do not work by themselves. So they become like lazy bowels. So it's important for us to always review the stimulant laxatives and see how long have they been on it, have they tried without it, have they tried other laxatives, why are we prescribing it. It comes, especially the senna, it can't come with abuse, especially for young women where they're trying to lose weight, where they use the laxative so the food doesn't stay in their intestine for too long and they don't absorb as much calories out of the food. And this is one of the things that normally community pharmacists have to look out for. Next slide, please. Now, as we said, opioid can cause constipation in 80% of the patients. and that's by slowing down the intestines. That's why we should avoid the bulk forming laxatives, because if you already have a lazy intestine due to the opiates mechanism of action, when they're going to have the bulk forming, that means you building up on this fiber inside the intestine without getting it out. So osmotic laxatives plus a stimulant laxative is very good combination. Softener laxative is also another one that we can use, like the doctor said. We should always aim to optimize the dose of the laxative to have a good response. So let's say that we told them to take 1 sachet of macrogol, and that is helping, but not enough, they're still struggling, then they can increase it twice a day or 3 times a day, depending on their response. Pregnancy, we said, due to the change in hormones, the diet, the physiological, the pressure of the fetus, all of those can have an effect on the bowel movements for women. So the number one advice is to give them dietary and lifestyle. So make sure that they're having enough fibers intake, good movement, they're not sitting for long. Then we can move to the bulk forming laxative, because we're looking at it as a fiber substitute. If that doesn't work, then osmotic laxative, and then stimulant if necessary. We do not like to go to stimulant, only because that will cause contraction in to the intestine, because the way it works. And sometimes this is not favorable in later stages of pregnancy or during very early stages as well. Especially, as we said, if there's unstable pregnancy, if they have a short cervix as well, then that can have an effect on the stability of the pregnancy. Next one, please. So that was the end of the slides. I did have 3 cases that I wanted to share. I looked up the cases later, so they're not on my slides. So I thought we can do an interactive kind of like session about these cases. Is that okay? Please feel free to unmute yourself or write in the chat. So my first patient is an elderly 75-year-old gentleman. He calls the GP practice and he is having problem with his opening his bowels. He's straining and sitting on the toilet for a long period of time. The symptoms, he's not on any medication. He is on blood pressure medication, Ramipril. His blood pressure is well controlled. No other medication. His symptoms are worse during summertime. What would be your recommendation for this patient? So elderly, symptoms worse during summer. He's not on any medication other than Ramipril. What questions would you ask? How would you approach this patient? Okay, yeah, drinking more water. Increase fluid intake, yep. Lifestyle review, yes. So I would ask if there has been any changes to the bowels, softener, okay. I would, number one, ask if there has been any changes to, exactly, red flags, any changes to the symptoms, where it has been any weight loss, any, exactly, thank you, somebody's reading my mind. Appetite, are they eating and drinking okay? And bowel changes, indeed, absolutely. Any blood in the stool? Yep. And what else? Okay, so we ask the patient if they have any blood in the stool and change in the bowel. How long has it been going on for? How's their diet? How's their lifestyle? How's their movement? And if we establish that everything else is fine and it's just because they are dehydrated, then we tell them to increase the fluid intake, especially if there's no contraindication, like they're not heart failure where there's restriction. So they can increase their fluid intake, increase their fruits and vegetables because they have a good water content as well. Avoid alcohol because that can be dehydrating. He's not on any diuretic, which is a good thing. And then we can prescribe them and tell them to, if he's straining and he's really struggling, we can give him a short stimulant, a short period of stimulant like Senna. Another one would be Macrogol or the Fibrogel. So either of those can be. Movicol or Docusate. So Movicol is the first rather than the Docusate. Docusate is a stimulant and a softener. So it is kind of like a second to third option. We first go for a osmotic, then a bulk forming, if possible, depending on because this patient probably is not drinking a lot of water. I will not probably go for the Fibrogel, only because I would worry if he's not going to drink a lot of water. So I'll go for the stimulant first. Any questions? Any comments? Okay, the next patient is a pregnant lady. She is on her second trimester. She's been getting gastric reflux. She's taking antacids, and she's been suffering with constipation over the past 2 weeks. She has tried to increase her fiber, but she's still constipated. Why do you think she's constipated, and what options would you give this lady? Increase fluid with fiber. Yep. So lifestyle is the first thing that we would ask the patients to do. Antacid medication causing constipation, absolutely. So this lady was on aluminium antacid, so we can tell her to discuss with the pharmacist about other options for antacid. Drinking enough fluid and exercise, yes. So she needs to drink more fluids, exercise, and change the antacid. And which constipation medication, sorry, laxative would you give this lady? Bulk forming laxative, next option, absolutely, because that will increase her fiber, and then she can drink water, and hopefully that would help. Great. So third patient, a 16-year-old girl comes in, calls in, or you see her on your clinic. She is having abdominal pain. She's been constipated. She hasn't opened her bowels for 4 days. She thinks she's constipated and she wants some Senna tablets. How would you deal with this patient? So lifestyle changes, increase of, okay, so she tells you that she's very active, she goes out for runs, she is very healthy in her diet, she eats a lot of fruits and vegetables, and she had her period about 10 days ago, so it's definitely not her PMS, she's not her period. Has she? No, this is the first time that she has this problem. Takes 8 to 12 hours. Okay, that is your Senna, yeah. Okay, so because this girl comes in and the first thing she asks about is Senna, I will be a bit aware about the Senna abuse because of the stimulant and because of exactly every use of Senna. So I would ask further kind of like information. Has she used it before? Try to lose weight, exactly. So I would take a better history from this younger patient and see what's causing the problem. Is it just an acute? Has she been under stress? Because we know sometimes stress means less drinking water, then that means maybe she's developing constipation. I will ask if she has she tried anything else? How long has it been going on for? And I would tell her probably Senna is not the first one to use. I will ask her to use an osmotic medication for laxative and tell her that it takes 2 to 3 days, but it's softer. Senna is not recommended because it can affect the stimulus of the intestine, and we try to stay away from it. And then if the problem persists, then she can book for another review, but definitely an osmotic like Movicol, Macrogols, or even lactulose. Yes. Just thinking, lactulose can be contraindicated on some patients who are have sensitivity. Forgot what's the name of the condition now. So sometimes we just need to make sure that the patients have no caution or contraindication to the laxatives, as we said, for the bulk forming, where we think there's an obstruction or the bowels are very lazy and the patient won't be, and there will be a bulk. So you will make the problem worse because the fibrogel will build up in the intestine and will block the intestine further. That is the end of my presentation. If you guys have any questions, any queries, you want any further information about anything that I just said, please ask directly or through the chat. Yes, that's the one. Lactocene. Yeah, yes. Thank you.
Does anyone have any other questions, any cases, anything else they want to add?
So what's my next Nisha, my next presentation? I think next month. What is it on? Sorry, I'm been inundated with work.
That's okay. I think it's on pharmacology, if I'm not mistaken, or am I confusing myself with the pharmacist forum? Let me just have a quick look.
Okay, just this would help.
I think our next forum's in January, and I think that might be Chandni doing diabetes.
Yeah, and then after that, yeah, so January we have diabetes part 2, because Chandni did diabetes part 1 earlier this year, and then in February we have pharmacology. I will email you guys, or you might have already seen the links to register for the January and February sessions. We don't have any more planned after February for now, but please register because I will only send the link to people who register via Eventbrite for reasons I described earlier. Yeah, and I'll send it to all your other paramedic colleagues as well, because I only sent it to you guys that registered for this session. So I'll be sending out a big comms.
And if there is anything specific, please email Nisha so I can include it in my presentation. If there's any specific area in pharmacology that you want me to focus on, because pharmacology is like I took like 2 courses at uni. So if you can make my life a little bit easier and kind of like I can focus my presentation to where it can help you with your practice.
Hello, there's a question.
Oh, sorry, John. Yeah,
there's a question in the chat.
Okay, 1 second. Okay. So, would you prescribe straight, sorry, away or try it? So now with the way that primary care is working, we try to kind of like send patients to the community, and that's would help reduce the pressure on primary care. So I would always say, if they can, if this is the first time, there's no underlying, it's a primary constipation, to discuss with their pharmacist. The pharmacist doesn't have probably access to all of the medication, blood tests, etc. So sometimes if you think this is a secondary cause of constipation or iatrogenic, then maybe you can prescribe them. But if it was an acute constipation, you can send to the community pharmacy. So hypertension, asthma, COPD, pharmacology, okay. So I don't listen to you. Regarding Monica, okay, hypertension, asthma, COPD. Okay, pharmacology for that one. Okay, let me just write a note for that. So okay, That's fine. These are the, yeah, I think this is what we mainly see in primary care for these three conditions. That's absolutely fine. I will do that. And of course, if there's anything else, please let Misha know. She'll be passing it on to me as new nice update. Okay, that's absolutely fine. We will do that. I will focus on hypertension, a little bit of respiratory, and a little bit of cardiovascular, because I think this is what we see mainly in primary care. Any other questions? Anything else that you would like me to talk more about or explain? No. Okay, fantastic. Thank you very much for having me, and I will hopefully see you again soon. Thank you, Misha.
Thanks,
Sarah.
Hella.
Thank you. Yeah,
we've-
we've just got like a quick survey if people can just engage with that for us before you shoot off. We just want a bit of feedback on the last year. It's the first time we've really done this, so we just want to know what's worked, what hasn't, etc. So hopefully you should get a little QR codes come up. So you can just scan it on your phone and then it should take you through to some questions. So yeah, just things like if you've been along, if you haven't, why, any sort of topics you want us to cover next year, yeah, etc. It should be fairly self-explanatory.
Ellie, I'm just waiting for people to join Menti, and then I'll go through the question. We can do the slides. If you're unable to use Menti, you can use the chat as well.
Great, thanks guys. I think that's everything from our end, unless anyone's got any other questions, thoughts, comments.
And we'll take note of the feedback that you guys have provided on the Menti, and we'll maybe try to redesign them for next year after February.
Perfect. Great. Thanks, guys.
Thank you, guys. Ellie, I'll sort the recording out and then I'll share it with everyone that's attended today. And yeah, I'll download the results from Menti as well.
Great. I wonder if maybe we need a place where people can look for these things if they haven't been able to attend. I wonder if people are struggling to access some of the recordings. But
we have like a library of them on the Southwest London Training Hub YouTube channel, I think. I just need to check that with Sarah. But like for the Pharmacist Forum, we made a kind of a page, almost like a library of all the recordings. So that's quite helpful. And we emailed it out with like QR codes and stuff. So we can do the same for this forum as well.
Yeah, I think that might be nice. That people can sort of access things.
Yeah. Okay, cool. Thank you. All right.
Great.
Bye.
Bye.
Bye.